like you keep reading very
Sure.
these and then reading other thing also. So collect quite a lot of information.
Yeah.
And probably I'm the only entrepreneur who find that roaming around.
Yeah, I even read Tara's all one.
That's good. That's good. This is an educational session. It's nice to get information out. There's too much there. We're trying to make it understandable.
Yeah, it's you make it very
Do you want some water? I'm gonna bring it.
We try.
I'm okay, yeah.
There's many good forums, but we try to have one where we're interested. So it's great.
Unfortunately, will not be able to make journal club today, so I'm going to a talk in PBS, but hopefully they'll record it and I'll get to watch it. So, okay. Yes, we're delayed a bit,
Actually, was working. Service leads, the drugs are just, for some reason, there's this weird pattern in USRDS. The patient is receiving like 1% of the day's supply for a specific drug. Like 2006, 2007, then all of a sudden 2008 is missing. There's nothing. Then again starts at 2009, 2010. Right? Not significant. It's like 10%. Which is weird. I don't know why.
We're already recording. Don't say anything I wouldn't say.
Stop receiving it.
Well,
Are you good with this being posted online afterwards?
eligibility after you get a transplant.
It's about 4 or 5 minutes before noon. Around then, we'll start informally first. I would say, Dr. Zack, tell us about yourself. Where were you born? Where you grew up? How'd you end up where you are?
Yeah.
Just chat for a few minutes, and then we'll kind of like roll the time, and maybe about like 12 or 4 till 5. Okay. There'll be a lot of people logging in.
I don't know, I don't think that's.
Yeah, not all of it, but some part of it, yeah. Oh, beautiful. Yeah, exactly. I was thinking, I don't know, maybe some issues with they changed pharmacies. That's not receiving as much as it's, I mean, it takes time for the system to kick in. I mean, I don't know, change houses or something.
I don't know, yeah. No, totally.
But yeah, as I'm trying to wash out period of people who previous, so I think I may exclude people who actually had it for a number of years. I'm thinking about it's like more than 90% coverage for more than 3 years. Probably that they were receiving it on that year as well.
You are computer.
Yeah.
Oh, hey, how's it going? I like the records. I was like, hey. Well, I think we're gonna keep running into each other, so.
Oh, yeah.
No urgency.
We need to send out his welcome message.
Yeah.
That's why.
I've never given one this experience for both of us.
So you were doing talk Friday or talk on Monday?
The seminar tomorrow.
Okay.
A number of pretty good YouTube tutorials on both bicycle.
Have they given you any instruction?
No, yeah, well, they give me generic instruction, they haven't given me the agenda.
So the one liner I was told when I did my talk was sketch out your first R1.
Yeah. R1 and then funding in the little corner for teaching style, so it's like. More than in my PowerPoint era, I don't write on the white, like a full whiteboard all that often, so that's all
At least
right.
it's not chalk.
Yeah, that's true, chalk
Yeah,
is
Colloquium chalk was chalk.
actual chalk, wow.
The login, but 1 minute. Quiet, solid. The rain has got this, but make good use of our times. I think this could be a super fun discussion on very dynamic topics that are very really impacting what people are doing right now. Before we dive in though, let's introduce us to Dr. Travis Zack. So glad you could be here. Tell us about yourself, Travis. Who are you? Where'd you grow up? How'd you end up where you are here?
So let's see if I can do this in a couple minutes. So I'm an assistant professor at UCSF. I work in pancreas cancer. I have about a day a week in clinic for a medical oncologist, and then I have a lab in AI model design and EHR data. A lot of what I do. I was born in Lahaina, Hawaii, which is, I think actually is a big, small town. I think a lot of people have probably visited there for a while, but then I think a lot of people now know more because it burned down a couple years ago. I studied physics at Berkeley and biophysics at Harvard for my graduate work. And then got interested in cancer due to a few instances in my family. Had a career transition, did a lot of graduate work in computational genomics, and then went back to medical school.
Was that back to medical school? Or that was like a new horizon.
Oh yeah, I was
Not-
totally physics, I was single molecule work, had no idea anything about medicine. So in fact, I often say, until I went to a lab, I didn't actually realize that there are MDs who also do research. I know that's how far away I was from the idea. And then I saw them doing it, I was like, wow, that is so cool that they're able to affect people here and now and in the future. So kind of captured me, and we applied, I went to medical school. I did graduate work in computational genomics, algorithm development, and bulk sequencing. We were doing all bulk sequencing at that time. And then when I got to my third year rotations in medical school, I got interested in this concept that I think a lot of us here in this room recognize is how little we use the data we actually collect for making clinical decisions. Like information overload, where there's so many data points and we're asking humans to make trajectory calls and understand all this complexity at point of care, and that seems inefficient and not the right use of the data. So got interested in working in that field, eventually wanting to combine that with genomics for predictive models. And so came to UCSF to work with Dr. Tulke for that residency and fellowship there. While in San Francisco, got married, 2 kids, 3.5 and 1, dog. That's where I'm at right now. Throughout that whole process, I've always been very interested in education, and this talk today, I think, is going to focus on not so much the stuff I do in lab regarding EHR work, but a lot of the ways that we can work with data and learning outside to make better doctors better at their job. We hope to talk about.
Excellent. We're really glad you're here and very topical. This is a thing that like our residents at Stanford right now are already using some of the tools you're going to show. And I had to ask them, what is this thing? Can you show me how to log in? How do you use it? And like, let's just call Dr. Zack over here and explain what's going on.
So that is part of my disclosure. So when Dr. Chen asked me to come. He didn't ask me to talk about any of that stuff. He asked me to talk about OpenEvidence. So I will, but my disclosure is I am a senior medical advisor. In fact, it's my first success, like true success as a mentor. One of my mentees is head ML designer there. So that's my connection. So excited about all the things he's doing. And I want to use it out. Instead of talking about it as a tool, because I looked it up, I think there are like 500 Stanford.edu addresses signed up and using OpenEvidence right now. So I think a lot of people know it. Then I want to talk more about what makes it such a challenging task and what are the things we have to think about when it comes to identifying the right source of an answer to a medical question, not just the right answer. Because I think I love that it's a really challenging question. It's a really interesting one. And it's something that requires a lot of work to get done with. So we will talk about that, and that's the framing that we used to talk about it. Do you mind if I dive in? Is it time to dive in?
Let's dive in, let's dive in.
So, I recognize a few of these before I dive in, sorry. This was supposed to be a joint talk, with Dr. Samuel Finlayson. He is a resident up at University of Washington and is not controlled over his schedule, even for something as important as this. So he is a co-collaborator in all of this, but was unable to make it today, so I just want to make sure.
And one of our illustrious Stanford grads
Exactly,
from many years ago.
yes, absolutely. So this is a background a lot of you already understand, but AI systems use a lot of different types of medical data, and they use it for a lot of different reasons. So right now we are digesting multimodal data across clinical notes, outside things like social media, patient messages, structured data, public health information, and then research and education material. There are a lot of ways we're using this. So there are patient-facing ways, clinician-facing ways, operation ways. So how do we make what we do more efficient? And then, how do we get paid for what I do? I think these are things that I'm not necessarily interested in, but someone is working on this, and possibly you will be using something like this in the near future for all of these. And besides clinical practice, we're using this in the research to come up with new hypotheses on how to organize, for monitoring. There's a conference up on campus by the FDA where they are all in because they have to deal with so much paperwork. I was really surprised at how excited some of them were about using AI tools, which is a little scary for me in terms of what they're actually doing with what we're giving them. But, and then science communication and outreach also. In all of these, generative AI has this opportunity to flip some of this paradigm we think about for precision and focusing the task towards the individual. And I've thought about this a lot with regards to clinical education. So this is often the trade-off we think about when you're an educator, and that is how personalized the teaching is and how many people you can give access to it. Right, on two ends of the spectrum, there's like open textbooks or even closed textbooks, right? Where I'm just gonna publish this, whoever wants it can go buy it and read it, or read the blog post for all it is. But it's not personalized to what information that person has when they come in or how they like to learn that information. And on the other end is why medical education is so expensive, right? What we feel a lot and has worked well historically is the right way to really teach how to be a doctor is one-on-one or one-on, 2 or 3 tops, learning from an expert clinician on that topic in the wards while you're working, right? Which is not very scalable, right? We have a lot of doctors, though not enough. We have less doctors who are educators and less doctors who are excellent educators, who are good at what they're doing and actually able to provide that. And so that leads to inequities in the kind of educational tools available. So one thought is, can we use artificial intelligence to kind of flatten this? So allow for personalization and universal access. And the couple of topics that I want to talk about today are along those lines. How do we kind of democratize the ability to ask precision learning objectives? So the first one is a passion project of mine, but I think it's fun to talk about. And I know that there are other groups doing this kind of work. This is a a project that actually spun out from something I was doing as an intern, and involving the New England Journal. And these Sam, as well as a phenomenal undergraduate computer science student, Nilu, and Raja at the NAGM have been working on this with us. And so, distributed medical education are a good way of taking one resource and giving it to as many people as possible. And there are a lot of good examples of this. Up to date, probably the most well-known current example of that. There are a lot of other ones, but the original one was the case records of the Mass General Hospital. And I love the story about how this came about because it really drives a lot of how we do education in the first couple years of medical school. And Dr. Cannon was a dorm mate with law students while he was in Boston. And the law school did a lot of this case-based learning, which means they look at a law case, they understand what the reasoning was for the pro versus the cons, and from that, they understand a bit more about the law. Medical school at that time was all didactics-based, and he really thought that that was mind-numbing and not a very passive way of learning. And so he came to the MGH and suggested these CPCs, which would be published in a way of learning through an individual case. And those have been published for over 100 years. And have kind of been, they were at the forefront of this idea of case-based learning for active learning for medical students that has been picked up by a lot of medical schools across the country. And I would say at this point, the majority of medical schools have some amount of case-based learning in the first couple of years, even before they get to actual cases and seeing patients. So from an educator perspective, there is a challenge. Case-based learning is time intensive and is time intensive during the creation. So you either can create one from scratch, which takes a lot of time and thought. It can be pulled from your personal experience and then modified to make sure you maintain the patient health information is not lost. Or you identify one from the literature and you have to make sure it exactly matches your case of interest. Proctoring the case takes a lot of time too, right? You part of the point case-based learning is an active process with the learner such that you can't have 40 people all going through the same case. That defeats the purpose. It's with 3 or 4 people with one proctor who really understands the case and learners who are actively engaged. So this is a resource intensive process. So as an intern, I know that this is super basic because I'm not a UI guy. But when I was an intern, I was about to become a resident. I was really scared about how am I going to teach on the wards when I'm just trying to keep people alive. And worked with the NAGM to create this. This was way before language models. I think BERT was published, but so NLP tools for how to find cases that are relevant to a patient that I'm currently seeing, so then I could show that case to my interns and students and walk through it. So it was a little project there, but it allowed me to connect to the NAGM and the CPC and think about how can we make these cases, which are still good even from 30 years ago, useful today. So this has been kind of an extension of that project now that language models and agents are really exploiting our capabilities. And this is, the goal is to, again, look through the case catalog, but now do it in a much better way, and then create a dynamic agent that allows you to walk through the case as a learner, depending on your difficulty, your education level, and dynamically adjust to it. So this is just an example. Again, not a UI guy, so this is just a project that the undergraduate has done. But the idea is you can ask any question you want. It has a repository of what information it has for the patient, and it can respond to it in a Socratic way. And this has been a fun kind of challenge, is that right now most language models during alignment are told to just give the answer, right? Like if somebody asks a question, give the answer. And how do you get these agents to work in a way that it actually is guiding someone towards the right answer as opposed to just giving it to them? So let's see, sorry. So obviously it's a little more it's a little more complicated than just submitting these prompts to API. Our process right now involves an intelligent RAG on different elements to get the right case. And then a manager that determines what's been asked, what information has been given, What is the right way to send a person towards a path to the right answer? Right now, our goals for this project. Move a little bit. I don't know why it's not. I will just talk through it here and then go to the next slide. So you first, of course, extracting cases so that we can get the information that's relevant for each case. And then constructing a lesson plan that's based on the past history of that learner and what they've learned previously and what kind of level we think they're at. And then have the tutor walk them through proactively, constructively, learning about the learner. And then the final one is summarize and evaluate the learner ability. So as an example of summarizing the learner abilities, this is at the end of each phase. So this is the history phase of a case, and it said, well, this is what you learned about the person. This is what I had to tell you to kind of look more at. AI nudges, we're calling them right now. So, ask about leg edema, given this person had a history of shortness of breath. Here are the information you missed after moving forward. And then this is my assessment of your final differential diagnosis and how that evolved and if that evolved appropriately. So this is, again, not to replace an expert diagnostician, but allow someone to work independently and understand things that they missed during medical education. The ultimate goal of this is synthetic cases. So obviously there are 1,000 cases, but there are a couple challenges with using historic cases and just regurgitating them. One is there is a limited set, especially for rare disease. And a lot of them are obsolete, right? We don't treat aortic dissection the way we did in the 60s anymore, right? So if we pull the case from that, you're gonna lose a lot of the management. Even the diagnostic decision process is different now than it was 20 years ago. And so if you just pull old cases, even if there are thousands of them, a lot of them are gonna be incorrect or at least misguided. The problem is, and what we're playing with, is how do you generate synthetic cases that maintain accuracy and complexity? So where you're not just fiddling around with silly things that don't matter, like if the person came from Colorado or if the age is 52 versus 54, but making meaningful changes that don't meaningfully affect the differential diagnosis or the next steps in management. And then the other one, this is something that I worked with Emily, who's a faculty here on, is how do you create cases that don't propagate this systematic biases and inequities that are present in the current case distribution. So a lot of times when we create case-based learning, we're doing it with the idea of this ideal patient. And the ideal patient, what that means is the patient that is most likely to get this, even if most likely is 55% versus 45%. Unfortunately, if all the cases are geared that way, then a language model trained on them, even in pre-training like GPT, understands that 99% of patients that have sarcoidosis are African-American females. And that's a non-ideal way to start with synthetic case generation.
Can you just underline the 1,000 cases right there, were they all CPC cases or this is something else?
Those are CPC cases. Yeah, those are the ones, because we're working with the MEGM right now. They just gave us all of them. There's actually about 3,000.
Sampled randomly or deliberately?
No, all of them. Yeah.
Okay, just
So
about
the whole
1,000.
library is available.
Okay.
And we're using a kind of informed RAG or whichever one the person wants to work. So, so for the determination of bias. Is that, yeah, so for the determination of bias, that was actually a Monte Carlo simulation based on what did a language model, what is it able to generate if you wanted it to generate synthetic cases. And there were clear deviations, not just average, but from even the epidemiological expectations. So again, I recognize that wasn't necessarily what, I guess you're talking about, but I thought it was something worth kind of describing. And so we'll talk a bit more about the other problem in medical education during continued medical education. So that is, okay, you're done with medical school, case-based learning is not something you're gonna do every day. Maybe you'll open up the New England Journal every once in a while. But you still have a responsibility to learn what's changed in your field and how does that affect the patient that you're looking at. And here's the problem, and I know this is not new for many people, but I want to put it in sharp relief here. So the problem is things are changing now faster than they ever have, And it is harder and harder for a single human being to keep up. And in a cartoon graph, the way I think about it is in 1970, if you were a doctor, you learned a piece of knowledge, a single piece of knowledge. There are two things about that piece of knowledge that made it very useful. One, it probably covered a fair patient population. Like, we weren't splitting patient populations into tiny minuscule groups of different types of preserved ejection fraction, heart failure, or whatever it happens to be. It was just heart failure. And you treat it with one drug. That's all you have. You don't have many options. And then the other is, there weren't a lot of changes very fast. So that piece of knowledge covered a large population, and it probably did you good for a number of years, right? Maybe even decades before it changed. And more, both of those are becoming less true, right? Each piece of knowledge affects less and less of the people you're treating, right? It only actually relates to a given individual, a small subset. And in 6 months, there'll be something new that may change whether or not that's accurate, right? And so in both of those ways, the number of data points you need to fully cover the patient population you're looking at and the decisions you have to make is growing and growing. That's a complex way of saying, the medical fire hose is a problem, but that's at least how I am thinking about it in terms of why it's a problem now is it's less of a problem previously. And it'll only continue to be worse. So went through that already. So there's a lot of people who are quantifying why this is a problem, right? So number of papers published each year, the amount of time that each primary care physician has to go through all the guidelines and actually apply them to their patients, why that might be responsible for medical errors if the person doesn't actually understand what the most recent guidelines or evidence are. So what is the problem OpenEvidence is trying to solve? And it's a lot more than garbage in, garbage out. I think the simplistic way so OpenEvidence is a medical answer for those who haven't seen it. It's a medical answer tool for physicians where you can type in a question and you get an answer like ChatGPT. Unlike ChatGPT, the answers are coming from citations that then you can go link to and read the paper. And so the way I always talk about it when I'm talking to trainees is the answer is almost irrelevant if you can't tell me why you got to that answer, right? Like, of course you don't want the wrong answer, but just because you have the right answer, if you can't tell me why it's the right answer, or at least go find why it's the right answer, it's almost as useless to me for practicing. I can't actually use that. So those citations are very important for something as critical as medical decision making. And so OpenEvidence looks to find the right answer within a specific set of of published data, peer-reviewed published data, and gives that answer to the physician with the citations to go check it. So the simplistic way of thinking about that is garbage in, garbage out. All you have to do is make sure that what you're putting into the system is things you trust, and then you'll get the right answer. And I would say that that's really only half the solution in medical information. So of course, the simplistic thing is it's not pulling from Facebook, right? It's not pulling from health blogs. It's pulling from peer-reviewed literature, society guidelines, licensed content like the New England Journal. Great. There's still a major problem with retrieval. And that major problem is most of that stuff is also wrong because of what I just discussed, right? So, and I put it in a few different buckets when it comes to retrieval, right? Is it relevant? That's kind of normally what we think about with a kind of RAG-based approach, right? Is this question match this snippet of text that I have somewhere in my library? That's a relevance question. That's kind of the easiest one. I think everyone's doing that. Then there are all these other questions to determine, is it the right answer? Is it recent, right? Is this something where something's already supplanted it? Or is this the most recent source that has that information? Is it authoritative, right? Like, I mean, I hate to say that where we're at right now, but right now, if it's in the New England Journal, if it's in JAMA, that's probably going to mean a lot more to us than if it's in a very tiny journal from other places that may have different medical practices, right? So there's an authority issue. And then there's the real one, which is a reasoning question, is what is the strength of evidence? So fine, they both have the same conclusion, or worse, they both have different conclusions. In that paper, what is the strength of evidence that led to that conclusion versus the paper that's saying the opposite? And I will say that is the frontier. That is not right now where we're at. But for me, that's where we have to get to. If you want to get to 100%, you have, oh, yeah, sorry.
Does it have to be the input, and does it have to be a question? Can it be used for like fact checking or? Like
Yes, yeah. So we'll get into how people use it, which I've had fun with from a research perspective. But it's whatever you want. I will say that if our gatekeeper doesn't feel like it is within the scope of our purview, then you get blocked. You say, oh, we don't do that. And at the beginning, there was a lot of things that were directly related to misinformation that we would try and hedge around, and now we're very good at like finding the right way to say, well, actually, your leading question about vaccines is inaccurate. Here's why. So the whole point of this slide is, yes, you have to start with the right set of information, but in medical, because of the pace and the way things change, that's not enough. And it's more complicated than just how recent it is, right? Because if you're in breast cancer, things change every other month, right? That's how fast things move. So many people are doing studies on it. If you're looking at like anaplastic thyroid cancer or some extremely rare disease, you're probably still using stuff from 20, 30, 40 years ago, right? Because data moves very slowly, right? So in that dynamic, like understanding of how things change as it relates to specific diseases are the kind of things that you have to do right to get the right answer. So this is not to be under the hood slide necessarily, but bottom line, there's a lot of things that have to go into going from a question or a fact check to getting an answer with the right citations. And we're continuing to build tools on that. One thing that's often asked about OpenEvidence is it's an out of the EHR program right now. You just go in, it's on a webpage. You just log in if you have a MD or an NPI and just get started. So why that versus something that's in the EHR? And I work in the EHR. Why do I work in the EHR? Because that's where all the data lives, right? If you're going to ask a question about an individual patient, there's so much information about that patient that you can't get into a single line, right? So what was the reason there? And the reason there was the right way to make something good is to continue to iterate on it, figure out why you're bad, and get better at it. And the right way to do that is get as many people to use it and tell you why you're bad over and over again. And so it was much easier to do that with something that we could just provide and get a lot of feedback on. And that cycle has worked very well. I've been working with Eric and those guys for a couple of years. And I do remember the first time they sent me the webpage, I told them there was no way I would ever use this, in its current form. And it was just, and by continuing to iterate, they've gotten so much better that now I use it daily, and a lot of people do. So a lot of people do into the EHR, a lot of people are out of the EHR. Why did they choose out of the EHR? Well, part of the reason was the speed. Like I said, it's just a lot faster to do things when you're out of the EHR. The other one is access. It's been so heartening to hear from like oncologists in rural Georgia. They don't want anything, they just email to say thank you because they didn't have access to this information and provided it. Or surgeons who do volunteer work in Africa. We have so many people, trainees in South America who are using it. So a lot of it is access, right? If you create an enterprise license where you have to pay millions of dollars to get this in your hospital, that excludes a lot of people who could use it. But then the other one is there's a lot of administrative logistics to getting that done. So it's a lot easier to just focus on building the tool.
So I don't think our OpenEvidence is not integrated with the EHR, right? It's
That's what I'm saying. So sorry, I want to be clear about this. OpenEvidence is not.
Okay, this was a possibility.
Why.
Okay.
No, it wasn't even, it's just say why, like why not, right? Like why not integrate? And the reasons were logistical, basically. One, you exclude a lot of people, and two, you spend all this time in meetings and administration when you could just be creating a good tool. So that was the kind of business reasons for why they did it. OpenEvidence is not integrated. We are talking about it because I think there is a lot of cool ways you could use it. So this is their user slide. Now we have about 3 million questions. I think that was January's like 5 million questions or something. I love that, because that's data, and I'm really interested in this new window for thinking about how physicians make decisions and what the gaps are in knowledge for physicians. So somebody asked, like, how are people using it? Well, what can you do with it? And so this is how people are using it right now. This is a small sample, right? So only 100,000 questions, just for today. And these are kind of the categories of the ways people, what questions people ask OpenEvidence. So a lot of them are treatment or management, but also it goes all the way to, find me that specific paper. I had a mentor who said that she had a breast cancer patient who didn't tolerate either of the current standard drugs. She knew there was a paper in the 80s that proved that you could use this older drug, and she went and found it, right? It was like, and so you could do that with PubMed. This just makes it a little faster. So where are people using it? So I would say that, it's kind of all over the place. So this is a map of the average number of healthcare providers per 1,000. That's on the X. So per 1,000 people, how many healthcare providers are in that region? So for example, rural areas will be on the left. More urban areas that are more connected and less healthcare deserts are on the right. And you can see there's it's a fair distribution, with one place is started at Mayo, right? And Mayo's pretty rural. So, so Mayo tends to have, it tends to be rather rural, but a lot of healthcare providers.
Everybody's a doctor in that
Right,
town.
exactly. At the Mayo Clinic, I think that's actually right. So like I said, these are just a few slides rather than talking about, I think like a lot of people know OpenEvidence. So I wanted to talk more about ways that we can think about using it as a window to understand the gaps in knowledge or how people are actually practicing. So I know that, put your glasses on, for this slide. But so this is a graph of what specialty the user said they were and what question types. So what kinds of questions that user asked with relation to specialty. So basically, obviously, immunologists are going to ask a lot of immunology questions, right? Cardiologists are going to ask a lot of cardiology questions. But what other things are important in their practice? Like what other specialties are important in their practice? You'll notice, the perfectionist here will realize it's not along the diagonal, and that's because things like primary care or general, hospital medicine don't necessarily have a specialty, right? So it isn't an N by N, it's an M by N graph. But it's really interesting to think about clustering of this. So kind of what information groups are there for specialties that need to know the same amount of knowledge? And there are groups that make sense, right? Cardiology and pulmonology, I think, are right next to each other. Pathology and oncology, I think, like to be friends. That's something we know quite well. But also we can learn a lot about, for example, one project that I'm working on is OBGYN across our group asks a lot of generalist questions, right? So, and I think they often, in a lot of cases, do become kind of a PCP, sometimes like oncologists are for some of our patients. So that's one axis, but then on the other axis, are there specific places in the country where the generalists are having to field more OBGYN questions, right? So where there's not enough access to a specific specialist and you have generalists who are popping up as requiring these specialty, the specialty knowledge that they weren't necessarily trained for. This is another way of looking at the question purpose. So this was the same graph I showed as a histogram, but now a 2x2 where we asked, if there were two things that this question was asked about, if it was both about efficacy and a side effect or about a population and a side effect, what is the correlation between those, right? So, how many people are asking questions about treatment and management and diagnosis? And so diving in again is specialty level. And so this is the, oh, go ahead.
Do you collect information about what they did after they got the answer?
Not yet. That's the problem, right? So that's an EHR question, right? And so for me, what's very exciting is the full loop. This is the question and the answer, but the full loop is, this is the patient. What question do I need to ask for this patient? What is the answer and what do I do with that answer? Right? That is the full loop and we are like stuck in the middle. again, we've gotten very good at that middle section, but I'm excited about the opportunity to move to the next step, which is the true medical reasoning as opposed to just synthesis is, here's a patient with all this complex data. What is the right question, right? What is the right question to ask to pull the right piece of evidence? And I think that would be an exciting way of like why integration of the EHR can be really exciting.
Step in a little bit of detail, you're kind of implicitly saying this. I think right now only doctors can sign up for this service. Is that right?
Correct, yeah, so right now, only doctors can sign up. I will say that you can, I should have put an email, you can just, there's a contact at OpenEvidence, you just email and we try and just like give one-by-one access. In all honesty, there's a couple reasons. There's a safety reason and then there's a financial reason. They're still on VC money right now, and having everyone in the world use it as their medical bank was getting really expensive. But more importantly, like for me as a healthcare provider, there are a lot of people that were using it for diagnosis as they would use ChatGPT, right? It's better than ChatGPT, but that's still not its purpose, right? And there's a potential for
Liability.
well, liability, but also cutting out MDs, right? Like, we want them to be talking to doctors about this decision making, not diagnosing themselves. It's a little different with ChatGPT. They're not setting themselves up as a health, like a medical answer system. They're just like, well, if you use them for medical answers, that's kind of your problem, right? We are a medical answer system. And so if a patient, or I should say, a layperson is using it for medical answers, there's a liability and there's, concern that it could be misused.
Up to date is open to patients.
Yeah, I think that's right, but there's a little difference in my opinion there, right? Like up-to-date are static pages where they are not personalizing the question to the answer. You have to go through all that and do it yourself, right? If I'm giving you the answer, and you take that, you can ask the same question 20 times until you try and get the answer you really, really want. So maybe that's true. Again, I'm not here to justify one decision, I'm just kind of providing context as to why. So they are starting to talk about things like institutional licenses. I know we've got a lot of feedback that's really helpful for research. And I actually have loved it for research myself, when I'm writing grants and things. And I think at a big place like Stanford, I don't think they'd have any problem with it, but it just requires an email.
And then information you collect on, I guess, was clearly specialty. You asked what's your specialty.
So yeah, so right now, because it's focused towards MDs, the sign up is really just your MPI and then the specialty information, which this is the only thing we're using it for, is like Travis getting to do research. So
it's super cool, but you also have geography. Did you have zip code?
No, because the NPI is tied. When you sign up for your NPI, that NPI is tied.
That links to the data.
Yeah, I mean, it's an imperfect, right? I'm sure people move all the time, so it's an imperfect termination of that. So again, this is all just for this week, guys, like having some fun. It's like, well, what are ways, so using this, right? So imagine these are your dimensions, right? These are the dimensions of the kind of questions you ask. Let's group all specialists into the same groups that they've self-identified with and ask what kinds of questions are these specialists asking, and do they kind of group together? So that's what this is. So we took all the specialists, put all their questions together and say, what are the patterns that different kinds of specialists ask with relation, not to the medical domain, but the type of question, right? Is this a management question? Is this a side effect question? Is this a question about a specific use room? And, as you might expect, the generalists kind of all cluster in the middle. And then you have us like surgery, cardiology, and oncology. We're all just asking treatment management questions, right? And that's what puts us together, right? It's like, well, cardiology, oncology, and surgery, those are all, but it's all just management. It's all just like, how do I do this, manage this patient and this patient? And then, like I mentioned, OBGYN, I was really interested, I think I have a slide here, right? OBGYN was on its own in terms of clustering. And that's because they had to ask a lot of questions about use in specific populations. And again, it's this idea of like often in OBGYN, there's not necessarily, they have to specify, I don't have just an adult, I have an adult who's pregnant. And don't give me the New England Journal paper about, your general adult, because there are many drugs that I cannot use, right? And going back to the EHR question, if that information was already known when the question was asked, that would make their job a lot simpler. Right? If I knew that your patient that you're asking about, just the basics of them, that would be very helpful for a physician. Some of these other clusters, I think I mentioned, but the specialties, cardiology, oncology, and surgery, they're all treatment management stuff, right? So it's mostly what define that cluster is really, they're just asking about treatment and management. I will say that I'm a little worried just based on what I did. I think cluster 3 was interesting, putting anesthesiology and psychology together, but I think because it was a lot about side effects and safety, which are two things that kind of those people talk about a lot. And then cluster 4, cluster 5, I'm a little worried about. I think it might be overfitting a bit. I only picked like a couple thousand providers, and I think there were just a few providers there that were probably, we're just picking up those individual.
How'd you do the categorization? How'd you label each question or each prompt as this must have been a question, this must have been.
Yeah, so I just had GPT do it. So I gave it 15 and I just gave it, so that's it's pretty basic.
Where do you get the list of specialties?
So when we put up the website, we created a list of specialties, and we have to add once in a while every time. Like we just added ophthalmology because someone's like, I want to sign up, and you didn't put ophthalmology on here. So I think it was started from like kind of the boards list. They went through the boards list, but it's pretty random. So this is the last thing I'll talk about because I'd love to talk a little, have lots of time for discussion, is how do we actually use these kind of tools to make guidelines better? So how do we use them to understand what people don't understand and focus on those and bring that information to the people who really know the field, right? So academic societies or medical societies are these groups, American Heart Association, American Diabetes Association, the National Comprehensive Cancer Network, where they've gathered the best minds in the country together to create things like guidelines that are, this is what you should do, right? This is all the evidence we have available right now, and today in 2025, this is what you should do for this country. So the American Diabetes Association actually reached out to us and said, look, we love what you're doing. We would love to figure out a way that we can work together to make our guidelines better. So this is just looking, again, it's not all of our questions, it's a subset, just to look at, here are their 17 chapters in their guidelines, and including, I guess, a couple of these others like summary or revisions. And we just looked, what are being used the most? Which guidelines are being used the most, or at least cited the most by questions asked to OpenEvidence, to get some sense of what's working, what's not working, right? Well, what do people actually need to know? But more excitingly, here are all the questions about diabetes across all these patients, all these doctors, right? And these are not by endocrinologists. These are all the questions about diabetes from primary care physicians. And we clustered them and then said, which of these cite your guidelines and which ones do not cite your guidelines? And so then we were able to show them clusters that were all pretty much the same question. Like a lot of them were very similar, right? Like, oh, my diabetic patient has a foot infection. I don't know what the right antibiotic to use empirically, right? Yeah, thousands of that question, right? And it's not actually covered in the guideline. And it's not that you necessarily need to cover every question in the guideline, but it brings it to attention that is this something that our society should consider doing the deep dive in and answering that question for the primary care physician. And so this is fun, and we're continuing to work with them in this iterative process. Hey, yeah.
It's kind of an interesting one because that's probably covered by like an infectious disease guideline.
Right, yeah, exactly. And so this is actually something we talk about when it comes to why this is very helpful for some of these complex questions that involve multiple comorbidities. Often I don't know where to look, right? If I have a person with chronic kidney disease and diabetes and they have an infection, do I look in the IDSA, I think it is, or do I look in the Diabetes Association, or look in the CK, what is it, Kiddigo? And this will kind of pull whichever one it is. So I totally agree that just because a cluster here does not cite the guidelines well, does not mean it needs to be in the guidelines. For example, the best one, I love working with computer scientists because there's so much we can learn back and forth, right? So I was working with a computer scientist on this project, And I asked him to pull all the diabetes questions, just using regular expression as a simple way, so then we could start with a data set. And he's like, wow, I found this one that is never covered in the ADA. And it was diabetes insipidus, right? Because which is not really is not diabetes mellitus, is what most people think about primary. So just because it's not covered in the guidelines doesn't mean it should be, but it creates a list of things that the society can go back to their meeting and be like, is this something worth considering? So I think that's really it. You know, things that I think a lot about is AI and responsibilities in education. And these are kind of the shared responsibilities and individual responsibilities as an educator and as a trainee. And all of these are important to think about when it comes to using artificial intelligence tools during your learning, whether it's during medical school or continuing education. And my big concern is I really think that AI tools can take us in one of two directions. They're going to be transformative. Are they good or bad for education? It's hard to know. And I think it really comes down to if you're going to use them passively or actively. So this is, I hope it's known at this institution, but this was a real question that was sent to OpenEvidence prior to HIPAA. Right now they're HIPAA compliant, but this was prior to HIPAA. This was a medical student who said, rewrite this so it's progressional, includes extra information showing that I looked stuff up, and then pasted the entire patient note. And so this is a very passive way of working. I will be honest, when someone forwarded me is tell me their school so I can talk to their dean. And they talked me down a little bit, but we ended up just correcting the student about the right way to use the tool. But this is a very passive way of using AI. Right? There's no education that's going on during this process, right? This is the person trying to get a pass on their clinicals. But there is a very active way to learn to use AI where you can learn faster than you ever could with Google or Touch. And the way I talk to trainees about using something like OpenEvidence for active learning, especially because we're outside of the EHR, is you have a really complex patient that has all the information in the EHR, and you can't give that to the model. You have to think about what is the right information and what is the right question to give the model for what you're trying to do. And that involves two things. One, what information do you need from the patient? So that I think is probably obvious, like what information from the patient do I need to give the model? But it also involves what information does the model have based on published literature in a broader sense? And what I mean by that is most evidence comes from randomized controlled trials where we define broad cohorts and compare outcomes in those broad cohorts. So that means that if you're asking a question about whether a drug works, you're not going to find a study that compares patients with congestive heart failure and CKD and type 2 diabetes and they're 65 years old and a female and had 3 prior pregnancies and whether or not they should get drug A or drug B, right? The cohorts are broad and the evidence behind them are similarly broad. You're not going to be able to answer that question. You can figure out whether or not they were in the cohort, and that's a really interesting question. But those are kind of active learning processes that I think about for input, right? So that's input active. Output active is you get an answer. What is that answer telling you? Is it right? And do you trust the sources, right? And that's similar, right? So that's being active about the like critically evaluating what the output of whatever AI tool is. And I think both are equally important for actually using these tools for growth and not just corner cutting. Sam and I put together an open source course about these kind of things called AI System and MLE, sorry, in medicine. And so, you know, my questions about these kind of topics are what are ways we can use a window into MD, use of AI to understand gaps in knowledge, progression of medical aptitude, reasoning requirements across practice types and others. I'd be very interested to get your thoughts on these kind of questions. And then just generally, how do we promote active and critical engagement in AI augmented workflows? As someone who does a lot of inside the EHR work, I think that's something I'm always challenged with and trying to understand is how to avoid automation bias and maintain active clinical decision making. And I think it's worth thinking about in all these contexts. Thank you.
Thank you, Dr. Zack. My questions online first, and we'll get to some rich ones. Clarifying question, is OpenEvidence trained on PubMed abstract, or also what about open source papers and licensed content agreements? Can it read figures or only text? Like, what does it get to? What's the source?
I will say, so it's mostly PubMed and clinical guidelines. It doesn't take anything that would require a license. So we didn't do any illegal scraping. Anything that it did get a license to, so for example, the New England Journal, we're using the full text, including the figures. And that's both for training and also regeneration. Open source, might have to defer that question a little bit. You know, I do think of most PubMed has a lot, you know, and Cochrane is another one that, you know, it does use. So I would think, you know, if it's peer reviewed for medical information, it has it. Even very low, you know, very rare, you know, low impact factor journals.
That's a loaded question though, but clearly a key value it adds is it kind of prior to this source is probably a better than that source, because a fair critique is like something on PubMed does not mean it is good. There's a lot of junk on PubMed actually. So you have to prioritize that.
Yeah.
But so how do you do that?
So this has been probably my favorite part about working with Eric. You know, like how do we create the fine-tuning models to understand whether this source passes the gut check, so to speak, even beyond getting, and really it's about labeled fine-tuned data on what physicians think is the right source. And the right way to do that, if you do that actually just agnostic to the date the paper was published and the impact factor of the journal and you know, these other features, it's still a point of discussion. We have models that kind of do both. That is, use metadata about the journal and ones that are blinded to that, but they've been trained on human data that does have that information, right? So it's kind of baked in. But I would say from my perspective, not using that metadata is just tying a hand behind your back. I think that that's when I'm trying to evaluate a paper. I know there's biases associated with, there's like this, you know, elitism that's associated with, but you know, the impact and where it comes from matters. And it should be.
It's a signal. It's not.
It's a signal, right? Exactly.
It is
Yeah.
correlated.
So it helps, right?
I mean, NEGM has the highest impact factor, but also is the most retracted journal of all.
Yeah, it's like I always think about, my mentor always said, just because it's in Nature doesn't mean it's wrong.
There's a clear, Don Yao said, wow, cardiology looks really hot topic. Walter Jancy says, how about non-physician clinicians like PAs, MPs, can they get into this yet?
Yes,
they use it differently.
can. So right now it's with an NPI. So if you have an NPI, and most NPs and AP or most APPs do here in the United States, so they can sign up.
And then any sense at this point, do they use it differently or don't really know at this point?
Yeah, it's a great question. So I didn't have time this week to look at medical students versus APPs versus MDs, which would be interesting, I guess, but also like, I think there's so much low hanging fruit that we can all learn from, and getting into those kind of questions can sometimes get controversial, and there's other more exciting things to think about. For example, one thing that I like to think about is we do have the date the NPI was registered. So we don't know exactly what level of training a person's in, but we have some sense of how much experience they have. And I'm really interested to think about the progression of question complexity or question types over kind of years of experience.
Okay. Let me take a question in the room. There's more online, but I want to let the room get in here too. I totally don't know who raised their hand first, but.
I think it was over here.
Oh, go ahead.
I recognize I like looked this way, I'm really bad at going this way. I should have switched over halfway through.
Thank you for the great talk. I noticed that you said the system is powered by large language AI, right? So it is based on a large language model, or you have a lot of models where, you know, a model is responsible for.
It's the latter. So there's a lot of different steps, as you saw, the pipes that go through it, there's a lot of different steps. A lot of those are fine-tuned local models for specific retrieval tasks or generation tasks. And it continues to be a very active research. What is the right way to put them all together?
Take another one over here. Yeah. Go ahead, in the back.
We go. Have you ever validated the answers?
Yeah. there are a couple different groups that are doing it. So we have internal validations that we obviously are using for fine tuning. But that's not very blinded. So the right way to do it is there are a couple of groups that are actually doing that. One's at Mayo, that's just starting, and then there was a couple published papers on it as well. So we're trying to help facilitate because I think that is the right way to do it. From my perspective, you know, what I'm very interested therein is what I call the true negative problem. So, and this is, I think, a problem with a lot of the reinforcement learning and health that people are doing right now. I'm an oncologist, but I went to internal medicine residency. If somebody gives me a question about someone who comes in with chest pain to the ED, probably I get it better than most lay people, hopefully, right? Like what the differential should be, the orders I should put in stuff. And so if I had to answer a question, you know, the question was asked to a language model, the language model gives an answer. I can look at that answer and say, well, it looks right. Sometimes I'll be like, oh, it looks wrong. Here's something that shouldn't be on here. Here's something that should be on. The true negatives, though, if you are not a subspecialist in that field, can be really hard to get right. So, for example, I'm not an emergency room doctor. If I was to look at an answer about an emergency room question, I could look and say this answer looks right. I can look at the citations and I'd be like, citations look right. They reinforce the question. They seem to be right. But it is much harder for me to then go back and do 2 to 3 hours of PubMed searching to be, is this the exact right citation I would use in this context? Is this the most authoritative? Is this basically the right one, right? There's a difference between looks right, which is, you know, it's been retrieved, I'm looking at it, everything makes sense, versus it is the right one. Now, if you ask me a question about pancreas cancer, or you ask a question about pancreas cancer and you gave me the answer in the citation list, I could very easily in 2 seconds say, look, it's missing this critical citation. I don't even have to look it up. I know exactly which one it's missing, right? And that's a true negative problem that's really hard to do if you're not the subspecialist, if this is not your exact field. And so one thing we're working on is, besides getting, you know, an answer that is right, the most right answer involves working with subspecialists in their fields to make sure questions that asked about their topic pulls up the exact right answer and fills in those true negatives. Because this true negative problem, I think, is quite challenging for these hyper specialized fields. I can't even remember what your question was.
Great. I'm gonna try to rotate a couple of people online and get some questions, so we'll cycle back, so we'll get people in the room and follow up. Ethan, do you want to go ahead and ask a question?
Hey, thanks for this. It was great. I really liked your graph showing how you decompose the steps, you know, the garbage in, garbage out, and then ranking the hierarchy of evidence. That was fantastic because so many product developers are coming to clinicians for the last step, right? Oh, doctor, can you just evaluate this, quality of citation, so on and so forth, right? And missing all they cannot articulate, right, any of the initial steps. So I'm curious, right? Have you seen a sense of like how good large language models are at generating citations to, you know, EMR sources and things like that? The reason I ask is I've seen a lot of engineers saying, oh, you know, with some of the more recent deep reasoning models, you can just ask LLMs to extract information, produce a citation to the EMR source. But I'm kind of skeptical, and I haven't found much evidence that shares, you know, directionally how good it is at doing that. So I'm curious, you know, at your experience with OpenEvidence.
So I will tell you my experience and thoughts, but so my experience is low. I know people are doing it. Like I said, I do a lot of research in the EHR. This idea of information extraction for the purposes of operations support, I think probably has a lot of promise and will be done very soon. From an academic perspective, I just don't find it very interesting. And I know that someone in industry will do it 10 times faster than I will. So I haven't done a lot myself, so I'll say that. I do feel like extraction of specific pieces of information from the EHR is probably not that challenging right now. Especially in a way where people can go back and check, right? Where you don't need 100% specificity and sensitivity. Personally, I actually don't think it'll be that challenging. I have not worked with any tools specifically myself, but having worked a lot in these kind of things for feature identification for downstream models, I think language models are pretty good at it. But again, that's a relatively uninformed. I'm sure there are like 10 people in this room who are more informed about it than I am.
It's doable. Some of it's harder than you think, but it's
Yeah.
doable. I think there's a student online. I want to give a chance for a student to ask a question. Is it Adrian? You want to ask your question?
Yes, thank you so much. It was very interesting. Yes, I have a question about if you already collaborate with medical students to fit, with their specific education needs, or this is not the current priority.
So we're not currently collaborating with any medical students. In the next few days, OpenEvidence is working on releasing a way to generate your own multiple choice questions and then save those to Anki. I don't know if people still use Anki. I used Anki all the time in medical school. So that, so we are thinking about features for medical students. For the this app for the case-based learning, that's something currently outside OpenEvidence. It's just a side project with people I know at the NEJM. But obviously it's for medical students, right? It's how to kind of study these topics on your own. So those are kind of the two active projects directly towards medical students.
We are 1 o'clock. Cliff, you've got to go. Tommy, do you want to ask a question before you leave, or?
That's all right.
Okay, next time, follow up on email. There are more questions online. Obviously, a deeper topic, we should follow up again and talk a lot of them more. I assume Dr. Zack.
I should have put my email, but you can give my email to anyone.
Dr. Zack at UCSF, and as you can see, very informative, very engaged, and we'll love to talk further. Thanks, everybody. And we will not see you next week because it's final exam week, but we'll be back after spring break. Try to quickly answer some questions online. Do you think knowledge graphs would help? Beyond just LLMs for better information retrieval, maybe quality of evidence, and what about hallucinations? Feel free to answer or not answer. It's
Yeah, so hallucinations, what I always say is they're a fun topic because they're a fun word. I think in a lot of ways we've built systems to avoid them, but there's a difference between quote unquote hallucination free or very, very hallucination rare and accurate, right? There are a lot of other ways we can make errors. So I would say the majority of the errors in both of these systems are not hallucination, right? By grounding it in citations and making sure that the information is coming directly from individual sources, you do a pretty good job of not making stuff up. But there's still a lot of problems with reasoning, right? Like you can still mess up reasoning. You can still do poor synthesis of multiple different pieces of information. And those aren't real, I don't consider those really hallucinations.
Yeah.
It's just as bad, right?
Yeah.
So anyway, those are my thoughts on hallucination. I can't remember what the other topic was.
They'll contact you directly. I think we covered it well. Thanks so much.